I'm Dr. Clare. I'm a diagnostic pathologist, and I've been researching COVID for over a year now. And I think if we're going to talk about vaccine passports, the first thing we have to talk about is the effectiveness of the vaccines against infections and transmission. And then I think it's quite important that we talk about transmission in general and what we do and don't understand about how this virus spreads. So the first, that's my bad. So the first thing to say is that we have a problem with the terminology. The word vaccine to members of the public means a harmless magical medicine that stops you catching an infection. And that's not really a definition that quite works with the injections that we've got here. And so that really creates a problem in terms of public perception and what they really understand. And I think two things that have really penetrated have been the 95% efficacy of Pfizer and the 70% efficacy of AstraZeneca. And that's been repeated and repeated for many, many months now, and is at the forefront of everybody's minds. But actually the reality on the ground doesn't quite fit that anymore. So where are we now? Well, the evidence does seem to show that these injections do reduce hospitalisations and deaths. But there is definitely a question around whether they're reducing infections. And last week, Robert Preston was badly attacked because he showed and shared data that Public Health England had produced on the rates of COVID among the vaccinated and unvaccinated. So the black and white graph is the Public Health England graph, and it shows how many cases per 100,000 people among the vaccinated and the unvaccinated. And you can see that in the 40 to 79-year-old age group, the rate was higher among the vaccinated, which was a bit of a puzzle. He was shut down by people telling him that that Public Health England were using a faulty denominator in their sum. They said that, so the trouble is we can't count how many people are unvaccinated. What we do is we take an estimate of the total population, we measure how many people are being vaccinated, and we subtract it. So that total population measurement is absolutely integral in our understanding of this. And the people who were criticising him suggested using the estimate that the ONS has for the total population. Now that estimate is based on the 2011 census data, so it's as out of date as it's ever going to be, because we haven't yet got the 2021 data. And it's modelled over the last 10 years. They're coming back to keep guessing about how the population has changed over that time. The Public Health England data is not modelled, it is a measurement. It is the number of people who are registered at a general practice and are currently resident in the country. Now the ONS number is smaller, and the effect of that is the equivalent of saying, well, if you have 10 cases among 100 people, that would be quite bad, but it would be not as bad as if there were 10 cases among 80 people. So that's what they've done. They've used this smaller denominator to say, oh no, it's much, much worse than it looks. So the other graph I've shown here has got the same data in the first two bars, and that last blue bar shows what it would look like if you used an ONS denominator. Now the trouble with the ONS denominator is that you can use those numbers and find pockets of the population, so subgroups in a particular community or a particular age, where up to 120% of people have turned up being vaccinated, and that's been recorded. So we have very good evidence that the ONS denominator is far too small. People, we know that those people are out there. The Public Health England number is also imperfect. We're never going to have a perfect answer on this. It's imperfect because they don't promptly remove people who've died. There are people who aren't registered with a GP. There might be people who appear to be resident, but actually they're living in a second home at the time. So overall, the answer with this data is it's nothing dramatic, but we can't be certain. We can't be certain on what's happening. So what we need to do is take a step back. Let's look at the bigger picture. Let's look at countries that have heavily vaccinated, including in children like Israel and the USA. And actually the UK is heavily vaccinated as well. And what we see are that in those places, the number of cases at the moment is higher than it was at this time last year. In fact, the number of deaths is also higher in all 3 countries than it was this time last year. And we can also do things like comparing Australia and Singapore. So Singapore is heavily vaccinated and Australia is catching up. But Singapore is not faring better than Australia at the moment. We can also see within parts of the country, regions that are heavily vaccinated, some of them have high case rates, which seems to be more to do with them having not had such a bad winter than actually the vaccination rates. And regions that have got low vaccination rates have got low case rates. Part of that could easily be that some people are not vaccinated because they know that they've been infected and have natural immunity. So trying to compare those populations is always going to have that variable in it as well. Now it's worth remembering that case numbers are not necessarily infections anyway. A case is defined simply on a positive test result. So why would we think a vaccination would have an impact on a positive test result? Well, let's just have a think through that a little bit. What we know is that in the last few weeks, of the positive test results, 3/4 of them have had no symptoms. Now, why would you have a positive test result and no symptoms? Well, there are sort of 4 scenarios here. It could be a test error, so some test results just go wrong through bad luck. It could be somebody who's genuinely got COVID and they're in that incubation period before the symptoms have developed. So that's the idea of asymptomatic testing, is that you're going to find these people who haven't yet developed symptoms. But there are other circumstances as well. So the testing that we're doing is incredibly sensitive. And in fact, it's dialed up so much that the sample that gets tested only needs to have 4 virus particles in it in order to be called a positive, for that patient to be called a case. What we know is that a sample with 5,000 particles at least is indicative of somebody who could be infectious. So we are calling people in cases when they have 1,000-fold less virus in their samples than what we would need to actually have a public health problem. And it's worth also knowing that people who are infected will be breathing out 100,000 particles a minute. So it's completely conceivable that you will have virus on the swab from the air or from the respiratory linings that has never even entered a cell, potentially, and be called positive. Now, if it did enter a cell, that person's immune system could just be on top of it, dealing with it, and they would never become infectious, and they would never develop symptoms. And without this very sensitive testing, we would never have known. And in fact, isn't that what we want the vaccines to do? That's precisely what we were asking the vaccines to do, is that when a virus enters a cell, it's meant to just deal with it so that you don't know. But these people would still test positive because of the way we're doing the testing. It's worth mentioning also that what the vaccines, what these injections are set out to achieve. It's producing an antibody in the bloodstream. It's a particular type of antibody, but it's in the bloodstream. It's a very different antibody that your body produces that for the lining of your respiratory tract. And that type of antibody can stop virus getting into a cell. But an antibody in the bloodstream can't actually do that. So there's no even biological, theoretical way in which it could do that. So with little or no protection against infection, there's really no justification for vaccine passports, nor for vaccinating children. It doesn't mean there's no justification for having the injection, and the evidence does seem to suggest that it does reduce hospitalisations and deaths. But they're protecting the individual, not the people around them. So let's move on to the second part around what we understand about how SARS-CoV-2 transmits. The truth is, there's a lot we don't understand, and there's a lot we don't understand in general about how respiratory viruses transmit. It's complex. There are multiple knowns and multiple unknowns, and it's incredibly hard to measure. The SAGE models are very, very simplistic, and they're based on a handful of assumptions. The primary one being that every single one of us was susceptible and has remained susceptible to every variant. And they have not adjusted these assumptions in the light of real-world evidence, but their assumption leads to the conclusion that any outbreak will inevitably lead to uncontrolled, exponential growth unless you reduce human interactions. And you can see here the models versus reality. What we have seen since then is that on Freedom Day, there was a massive fall in cases. So this model didn't fit. And likewise in Australia, we've seen a massive rise in cases despite hugely draconian measures for a very long time. So this type of evidence has to call into question the theory that imposing these restrictions and lifting them has any impact at all on the viral behaviour. So why haven't lockdowns worked? Now, there are broadly two types of respiratory virus. There are those that spread person to person, like measles, in a continuous chain of transmission, which is uninterrupted by season, and in which every susceptible person will be infected when they come across it. This is the close contact model, and that's the model that SAGE have been using. Then there is a different model, which is based on influenza, and it's the one that we don't understand very well. It's much more complex. So with this model, the whole population is exposed to a new virus each winter, but only a minority appear to be susceptible, and that minority will catch it that winter. But to complicate it a bit, there is person-to-person transmission, so there are some similarities. And we do have evidence for SARS-CoV-2 of person-to-person transmission, but there are lots of areas of ambiguity such that that cannot be the only route of transmission. So the influenza model is a good fit for what we've seen with SARS-CoV-2, and it can explain why these interventions haven't really worked. So what we see with influenza are seasonal surges, and nobody really understands why. It's been measured for centuries, so we've got great data, we understand the patterns, we understand what might happen, we just can't explain why. Spread does appear to occur person to person, but there's only ever a trickle of cases in the summer, and then you have a surge at the beginning of the season, which also happens to occur in warmer climates like Australia and California at that time of year. And each winter, between 5 and 15% of people will become infected somehow with that circulating influenza virus. If you spend an hour indoors in a public environment in winter, you'll be exposed to an infectious dose of influenza. But most of us don't get infected because we're not susceptible. And once that 5 to 15% of susceptible people have been infected, we reach a kind of quasi-temporary herd immunity. And then cases peak and they fall and reach negligible levels until the next winter. So we can see these classic epidemiological Gompertz curves, but they only affect part of the population. Then the following winter, those who had it the previous winter are protected and immune, but a further 5 to 15% become susceptible somehow. No one understands why. No one understands why these people were not susceptible in the summer, or why that same person was not susceptible the previous winter. And a novel influenza virus can take up to 11 winters before it's worked its way to the full population and we reach a kind of full herd immunity, and then that strain will disappear. So this poorly understood winter trigger actually occurs twice each year. So we have an early one and a variant that will reach this quasi-herd immunity, which then falls away midwinter, and you get a second surge with a different variant in the second half of the winter. Now, what we saw in winter 2019 to 20 was that the first half of the winter season was dominated by an influenza variant, and then that fell away and has disappeared. And as that was falling away, so at the very moment you'd be expecting a surge of a new influenza variant, we saw a surge of SARS-CoV-2. Now, interestingly, that surge, well, the falling away of influenza and the surge happened 3 weeks earlier in Italy than it did in the UK and in Sweden. So these are quite different viruses, But I think the fact that it surged at that time when we were expecting a new influenza variant is a good enough reason to closely examine influenza transmission as a model. So the critical point is that many, many more people are exposed each winter to influenza than infected, and it is airborne and infuses indoor enclosed spaces. And for most of us, our immune systems are enough to protect us, but for those who become susceptible in any particular year, they are unlikely to be able to avoid infection. Now, we have influenza vaccinations, and these are thought to have had an impact on hospitalisations and mortality, but the evidence that they have had reduced transmission or infection is really very weak. And comparing the transmission of SARS-CoV-2 to influenza is not the same as dismissing COVID as being just like the flu, because COVID isn't quite. COVID causes more hospitalisations. It places a greater demand on intensive care services, but how we respond to it is predicated on understanding how it spreads. So we do need to think about this influenza model. The person-to-person close contact model can't explain certain characteristic features of influenza. So for hundreds of years, there have been reports of boats at sea that have been weeks without human contact who then have influenza outbreaks. There was a study that showed viable, intact coronavirus, actually not influenza, it was a different coronavirus, 10 miles away from where the infected animals were in that situation. So we know it can spread through the air significant distances. It's now widely accepted that it transmits as aerosols in the air, like influenza, and it's been isolated from hospital ventilation systems. So in the words of Chris Whitty, airborne risk is indiscriminate. It is much more difficult to interrupt than other transmission routes. In addition, there's a growing body of evidence of something actually slightly strange, this. Numerous viruses are present 4 to 12 miles above us in the troposphere, and in the right environmental conditions, they come down to Earth. And for decades, nobody could explain how the exact same genetic profile of influenza would appear simultaneously in different parts of the world, miles and miles apart. And close contact spread just could never explain that, but this tropospheric spread might. The close person-to-person spread also can't explain certain things about COVID. So, for example, there's 3 major anomalies. There was a fishing boat from Argentina that set sail, having made sure the whole crew were tested negative, and 5 weeks later they had an outbreak of COVID, having just been at sea. There was a Sri Lankan garment factory where 1,000 people were diagnosed within 2 days of each other. There was no super spreader identified, there was no COVID community at the time. And there were several stories from Australia recently where they never could identify a source of infection, despite the fact at the time there were very, very few cases around. You'd think you'd be able to find them. In fact, in Canada, they've published their test and trace data, and they've shown that even at times of very low prevalence, 40% of the cases they never find a source for. So this simplistic stage model of a single exponential wave may be interrupted or delayed by an intervention. It just doesn't match reality. The models are superficially attractive but contestable, and they're entirely based on this assumption that human contact is the only means of slowing spread. But they can't explain these mysteries, which clearly show something else is going on. Now, a lot of us are attracted to simple answers to complex situations. And I mean, I would say that I'm guilty of that too. So last autumn, when we had seen the spring curve rise and die away, and the mathematics of that curve quite clearly showed a constant slowing of the growth. So even though the curve was going up and down and doing all sorts of different things, the growth was a straight line, uninterrupted by the interventions that we had. And that is what you see with the classic complex curve, and it indicated that that was over. It looked like it was all over. And it wasn't, it was premature. We've seen subsequent waves of COVID. But lockdown did not affect those waves. Numerous papers have shown beyond doubt that cases fell in countries in a way that was too early for the lockdown, and in other countries it was too late for the lockdown to have been the cause. And what we saw after spring was that worldwide, antibody levels to COVID were low, regardless of how much intervention there had been. There's very few people actually got it, no matter what went on. Now, the household transmission rate is a number which tells you the proportion of people that people live with who catch it from them. And it's surprisingly low, and has been throughout. It's 1 in 10. So the other 9 in 10 people that don't catch it, despite living with somebody infected, aren't just lucky. I think they are the ones that are not susceptible. And SAGE has never managed to explain how key workers, including people working in hospital, who've been heavily exposed to the virus, managed to be unaffected by the Wuhan strain, unaffected by Alpha, and then succumb to the Delta variant. And that's not an exceptional scenario. That happened in a significant way to health workers. So because Ferguson and his modelers have stuck to this simplistic model of this uninterrupted chain of transmission, they've blamed everything on human behaviour. But they have been utterly confused themselves by the lack of rebound in the summer. So in summer 2020, as the curve was falling, you remember that people started to gather in big groups, and we had the VE Day celebrations, the packed beaches, the marches, and all of these were meant to precipitate another rebound, and they never ever did. And so, by their logic, that meant it couldn't transmit outside. Now, what we saw this summer, as cases were rising, was big outbreak at the Utrecht Music Festival, outbreaks at the Euros at Wembley. We recently had the Boardmasters Festival in Cornwall with a big outbreak. So at times of rising cases, it can transmit outside. The further lack of a rebound in the United States, when life returned to normal, in lots of places, they're living normally in Florida, Texas, Georgia, South Dakota, South Carolina, Mississippi. There was no significant consequence when they made that decision. That does not fit the simplistic model. The reality is clearly more complex. And finally, the peak and fall of cases in England at the very moment when restrictions were lifted on Freedom Day, resulted in Ferguson pivoting from saying we're going to reach 200,000 cases a day to 9 days later saying it would all be over by October, which really can't help but conclude that he's just guessing and not looking at the real world evidence at all. So there is support for this influenza model hypothesis. I would say that it is a hypothesis. Some of it might be right, some of it might be wrong. We have now seen influenza come back in India, which is interesting. And there are ways that we could test this hypothesis. So if we see another wave this winter of a new variant, well, that contradicts Ferguson's it's going to be all over in October. If this further wave affects 5 to 15% of the population, as we've seen in other ways, well, that would support this model. If it peaks and falls irrespective of intervention, that would support this model. And if we see similar waves internationally, what would be very interesting would be to see a follow-up of those people who'd been on the Diamond Princess and find out whether any of them had been exposed to subsequent variants and become ill. So early models are always going to be more inaccurate, but as data emerged, the refusal to adjust these models became less and less forgivable. Numerous scientists have been pointing out for well over a year the problems, and rather than sage listening, debating, adjusting their hypothesis in a scientific way, those voices have been quashed and censored. The latest failings of the SAGE models must be a reality check. Other hypotheses, including the influenza model, need to be given due consideration, and these overly simplistic models, which fail to explain patterns in real-world data, need to be discarded for good.